Friends, welcome to my workplace at Ranaghat, West Bengal, India. This cataract appears like an intumescent cataract, but it is not. Let us observe this surgery. This is the main incision at around 10:30 o'clock. About 3 o'clock hours away, this is a side port on the left side of the main incision, and about same distance away, this is another side port on the right side of the main incision. Now my plan is to stain the anterior capsule of this white cataract with trypan blue dye. An air bubble has been injected, and the dye is injected. Care is taken to apply the dye over all parts of the anterior capsule. There should not be any unstained area. And then the dye is washed out. This is a bit of adrenaline to see if the pupil dilates little more, and in this case it did dilate little more. So this is washing out of the dye, and now 2% hydroxypropyl methyl cellulose is injected into the anterior chamber. The BSAs and air bubble are replaced by the visco, and now capsular access is to be done. A 26 gauge band needle is introduced. As soon as the capsule is incised, there is no leakage of any oily fluid, so the intralenticular pressure is not high, but there is some convexity of the anterior capsule, so we can call this a pre-intumescent cataract. And in this case, the rhexis can be done at on-go, but care is taken not to do a large rhexis. The size of the rhexis should be 5 mm, not more than 5 mm, not less than 4.75 mm. And now we can see there is lot of loose cortex. So within a few days this cataract, within a few days or few weeks, this cataract would have gone into the stage of intumescence. And now the tip of the phaco handpiece is introduced into the anterior chamber with its bevel down. The loose cortical matter is removed, and now the nucleus is rotated nicely, and now I'm going to do direct chop. Bevel is up, the tip is buried into the substance of the nucleus. The nucleus is held very firmly, and then the nucleus is chopped. This nucleus is brittle and there is no leathery fibers. The nucleus, this kind of nucleus, can be chopped very easily. Each nuclear fragment is emulsified with ultrasonic energy, which is 60% in this case. Flow rate is 45 ml per minute. Vacuum is 450 mm of mercury, and this is Cataract 3 from Otley, Switzerland. This is the heminucleus. It is chopped, and this is the last nuclear fragment. At this time we can reduce the vacuum to about 200. With this machine we can remove the chopper for better stability of the anterior chamber, and the emulsification is carried out with low vacuum and low flow rate. And now there is lot of cortex in this case. I'm going to use bimanual irrigation aspiration for removal of cortex in this case. The irrigation is from the right side, aspiration from the left, and see how easily the cortical matter is coming to the aspirating port. And in this case I didn't have to change hands. I could remove all the cortex from the left side port, going through the left side port. Yes, so all the cortex has been removed. Posterior capsule is clean. The incision is enlarged little bit because I am going to use a B cartridge. And now this is hydroimplantation. Hydroimplantation means the antechamber is filled up by irrigating probe and the intraocular lens is implanted under irrigation without using any viscoelastic substance. The lens is nicely in the capsular bag and the optic is all around. The optic is covered by the anterior capsular rim. So the size of this rhexis is about 4.75 to 5 millimeter. This is a bit of moxifloxacin. Now the side ports are hydrated with BSS. BSS is used to hydrate corneal stroma on either side of these side ports. And then this is the final lavage of the anterior chamber. Watch the visco from the posterior surface of the cornea. From corneal endothelium, visco comes out at this time. A gentle stream is irrigated towards the cornea, and this can be done very nicely with the Simcoe. Cleaning of visco from corneal endothelium. All the wounds are nicely checked. Few drops of moxie is applied over the cornea, and then the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.